this webinar on Carbetocin in action, case studies from labor, sponsored by Heatro. Doctor, as you all know, Heatro has got 25 years of excellence with 36 state-of-art manufacturing facilities. We have 300 plus products in our portfolio and presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. We have Asia's largest manufacturing facility as Visakhapatnam, Andhra Pradesh. Heatro Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching out to customers across India, wide range of products encompassing multiple specialties like gynecology, dermatology, pulmonology, etc. We pioneer in quality and innovation. We have distinction of bringing 4 biosimilar products to market within 5 years of initiation. For this webinar, Carbetocin in action. Doctor, as you all agree with me, PPR is a condition which is potentially very dangerous and can lead to disaster. Although there are many papers and documents on the role of Carbetocin and PPH, we always like to have our own doctors' experience, their own hands-on experience of use of Carbetocin, for which today we have got Dr. Tanusree Gupta with us to share her experience. Welcome, madam. Dr. Tanusree Gupta is MS FICOG, currently Director Senior Consultant Obstetric Gynecology at Udyan Healthcare Private Limited, Secretary of Association of Private Gynecologists of Lucknow, 33 years of experience, and field of interest is high-risk pregnancies, endoscopic surgeries, and infertility. Madam is member of FOXY, IFS, Peaceful Society of India, Indian Menopausal Society, and does a lot of research work on morbidity and mortality in eclampsia. Has been speaker at various forums and organizing secretary for workshops at UA FOXY 2017, Eurogynac 2018, IG, and local convener for workshop AICOG 2020 for improving obstetric skills, writer and editor of Manual of Improving Surgical Skills in Obstetrics, AICOG 2020. With this brief introduction, I welcome Dr. Tanusree Gupta to this webinar to share her experience. Welcome, madam, once again. And you can share your PPT. I will stop sharing.
Yeah. Thank you, Dr. Prashant, for that elaborate introduction. With a warm good evening to everyone who has logged in. Let's talk a little bit about Carbetocin. Now, we all know that Carbetocin is in use since 1997, though not in India, but internationally. In many of the countries, Carbetocin was available. So now today we'll be discussing about my experience with Carbetocin, and of course we'll like to share your experience too. So Carbetocin is the smarter, superior and safer choice of a utrotonic. So before we go to discuss Carbetocin in detail, let us talk about a few different type of cases where I have used Carbetocin. So most of these cases are my own, and I have been using Carbetocin since the launch of Carbetocin. I think it is almost more than 2 years now, 2 or 3 years. So let's start with case number 1, which is a very normal case of a multipara with moderate PIH for vaginal delivery using Carbetocin. So we have para 1, gravida 2, 28 years old female with moderate PIH diagnosed at 28 weeks and since then managed with antihypertensive and close monitoring. Presentation was vertex, and due to PIH, labor induction was planned at 38 weeks. And she progressed well. We induced her with Serviprime and then we gave her a little bit of oxytocin. She progressed well and had a vaginal delivery with careful monitoring of the blood pressure and fetal heart. And she delivered a healthy baby. And after the delivery of placenta, 100 microgram of Carbetocin was administered for the active management of 3rd stage of labor. And hello? Yeah. So am I audible? Hello?
Yes, doctor.
Yeah. So
Yes,
effective uterine contraction and control of postpartum bleeding was there. And all the parameters were well maintained. And there was no adverse effect as such, and there was no PPH. So this was the first case. Then coming to the use of Carbetocin in C-section. Nowadays, we are using in routine Carbetocin for C-section. And just to see that this is a case of a little bit high-risk pregnancy. She was a 32 years old female, gravida 1. She had IVF twin pregnancy and also had gestational diabetes mellitus and hypertension. Both the babies were presenting as cephalic presentation. Her GDM was managed with diet and insulin, and hypertension was managed with antihypertensive. And because of her high risk and precious pregnancy, a C-section was decided and it was performed under spinal anesthesia. And in the postpartum management, we administered oxytocin 10 units, but then when the uterus did not contract adequately, there was mild atonic PPH. Then we administered carbetocin as the second line uterotonic agent in this, and the uterus contracted well, and there was no further PPH. The patient was monitored closely for any signs of further bleeding, and her sugar and blood pressure was also monitored in the post-operative period. Both the babies were monitored in nursery, and the patient with both the babies were discharged in a good condition from the hospital on the fourth post-operative day. Now, this is an interesting case. Very recently, this case was hardly, I think, 10-15 days back that we operated upon. She was a primigravida with 39 weeks of pregnancy with posterior low-lying placenta. Though the placenta was not covering the os, it was reaching up to the os with a single loop of nuchal cord, and the A5 was 5. And the patient and her attendant decided that they will like to go in for an elective C-section, I think, which was a good decision. And LSCS proceeded in the normal way. An alive male baby of 3.5 kg was delivered as vertex. Placenta complete with membranes delivered. But following the delivery of the placenta, there was mild atonia of the uterus. There was no heavy bleeding. The blood loss was not very significant, but then the consistency of the postpartum uterus was not as desired. So initially, we had given carbetocin. Like in most of our elective seizures, we are using carbetocin. We gave carbetocin 100 microgram. We normally give it IV in the OT. But even after 2 to 3 minutes, the uterus was not well contracted. Then we again gave 10 units of oxytocin, still not got the desired result. Then we gave her prosthodin and also 1 ampule of methergine. This case I wanted to discuss because we had to use so many uterotonics and there was basically no risk factor for uterine atony in this patient. So, PPH or uterine atony can always not be predicted. It can just happen many a times. So now with the discussion of these three cases, I think we proceed on to discuss the postpartum hemorrhage and overview and the use of carbetocin. Dr. Prashant, you want to add anything?
No, madam, nothing. When we come to the discussion of from the questions from panel, I will ask questions on this.
Okay.
Currently, nothing.
So we continue with the
Yes,
postpartum hemorrhage. Nothing much to say about the postpartum hemorrhage. You all know that PPH is a loss of at least 500 milliliter of blood following vaginal delivery or 1 liter following a cesarean section. And PPH is common and can occur even in low-risk patients. It is the leading cause of maternal mortality in our country and most of the other developing country. And it is also the primary cause of increased number of maternal deaths globally. So this shows the postpartum hemorrhage. It's unfortunate yet common, leading cause of maternal mortality, almost accounting to about 35% of all maternal deaths. And MMR in the developing country was 240 per 1 lakh live deliveries compared to 16 in the developed countries. And the global PPH incidence is 14 million women suffer from PPH. Its incidence in vaginal delivery is somewhere between 2 to 4%, and it is more so in case of a C-section, accounting to almost 6%. So we see that 38% of the maternal deaths are due to PPH. 25.7% of global deaths take place in India, and out of that, 2/3 of these attributed to PPH. So India as such has got a higher maternal mortality rate as compared to the developed countries. Now, coming to the etiology of postpartum hemorrhage, they are the 40s: tone, uterine tone, inability of the uterus to contract, which may lead to continuous bleeding, or it can be the coagulopathies, thrombin, that is, failure in clotting mechanism, or trauma. Trauma can be anywhere in the birth canal, right from the vagina, the cervix, the uterus, or there can be inversion of the uterus, and then there can be tissue, that is the retention of placenta and clots and abnormal placentation. So what clinical findings do we find in PPH? There is, of course, that vaginal bleeding is there, and if there is uterine atony, then we find enlarged and not well contracted uterus, a flabby uterus per abdominally. There can be abdominal tenderness also. There can be increased abdominal girth, and there can be signs of maternal shock depending upon the amount of the blood loss. So this table on my right shows the degree of the shock according to the volume of the blood loss and the blood pressure changes and the symptoms and signs in the mother according to the blood loss. So we see that it can be mild, moderate, or severe, and the blood loss where there is very minimal change in the blood pressure, or there can be palpitation, dizziness, and we can see here very much that gradually there is a fall in the systolic blood pressure, and there can be changes like sweating can be there in the mother, pallor can be there, tachycardia can be there, air hunger can be there, the mother can collapse, and there can be complete renal shutdown, or there can be oliguria also. Now, how do we diagnose the PPH? Initially we evaluate the patient, we assess the patient status, we see for tachycardia and hypotension, and we see for the other vital signs and also see for the blood loss. How do we examine at the stage of hemorrhage? Now, practically, we have to see for the atonia of the uterus, and we have to see for any trauma in the birth canal. So we look for lacerations, hematoma, or if it is a C-section, we look for whether there is any extension of the incision, or if there are any broad ligament hematomas, or there is any big bleeder. So all these things we have to see, and we have to also check for the uterine inversion, though it is very rare in our scenario nowadays, but we do have to look for the uterine inversion. And yes, the cervix being open, we can just very gently explore the uterine cavity for any retained placental tissue. And if needed, we can go in for a bedside ultrasound to check if the uterus is contracted or if there is any presence of hemorrhage in the peritoneal cavity. And laboratory assessment can be in the form of complete blood count, hematocrit, platelets, and coagulation studies along with the serum fibrinogen levels. Now, here we'll discuss a little bit about the approach towards postpartum hemorrhage. So, these can be under the three headings: poor uterine tone, if there is tear or trauma, and then retained tissue. So, since this is more about the uterine atony, so what we do is we palpate the abdomen. The uterus is relaxed, boggy, and soft, and it may be felt above the umbilicus if uterine cavity is filled with blood and clots. Investigations here, we will send a full blood count. We'll send a coagulation profile, and we will send the electrolyte and blood urea. If the patient is not responsive to fluid and blood replacement, then of course an abdominal ultrasound is also needed to exclude uterine rupture or to see for intraperitoneal bleeding. Now, how do we manage uterine atony? Normally, we are doing the active management of the third stage of labor. But still, if the uterus is atonic, we can use any of these uterotonic agents like the oxytocins, and then the carbetocin, the prostaglandin, the ergot alkaloids. And if the medical, all these measures fail, then you can use the uterine balloon tamponade. And of course, if everything fails, then the last resort is the surgical management in form of hysterectomy, or at times even internal ligation can be needed. Now, in case of trauma, we have to see the site of the trauma, the tears, the lacerations, and act accordingly. During inspection, we can externalize the uterus and see for the extension of the incision or any other cause of bleeding from the uterus or the adnexus. Now, ultrasound may help in identifying free fluid in patient with uterine rupture, and many a times where the facility is available, we can resort to pelvic arterial embolization. Now, retained tissue, when the cervix is open, we can very gently examine the uterine cavity for any retained piece of placenta, and manual removal of the placenta or retained products of conception can be done either under regional or general anesthesia. And then coming to coagulopathy, now if the patient is in any form of coagulopathy, which can be more so in patients of HELP syndrome, or you can say in PIH patients, in these type of patients, we can manage these patients with blood transfusion or with FFPs or the clotting factors, and attempt should be made to identify the cause in the women who are bleeding in parallel with resuscitation. So on one side, we are doing the resuscitation, and on the other side, we are trying to find the cause, whether it is atonic pH, whether it is traumatic, or whether this is due to any retained tissue. Now coming to carbetocin, which is the new heat stable formulation. This is available in a room temperature stable formulation and convenient vial presentation. So why carbetocin is superior to what we have been using for such pretty long time, that is the oxytocin? Because it has got a better half-life, it is heat stable, shelf life of 24 months at 30 degrees centigrade and 75 degree humidity, and avoids the need for cold chain storage and logistics. So in countries where the cold chain storage or transport facilities are not up to the mark, there, because oxytocin we need to store at 2 to 8 degree. But then in those type of circumstances, we can use carbetocin, though it is slightly more costlier than our conventional oxytocin. So what should be the use and time of the uterotonic agents? Normally, we can administer the uterotonic at the time of the crowning of the baby's head or delivery of the anterior shoulder, or even at the end of the second stage of labor or following the delivery of the placenta. I think most of us are doing the active management of the third stage of labor by either oxytocin or carbetocin. So the molecules available with us are oxytocin, the age-old molecule that we have been using for years. Then now recently carbetocin has been added to this, which is a synthetic analog of oxytocin. Then methyl ergometrin is there. Syntometrin is a combination of methyl ergometrin and oxytocin, though I never had the opportunity to use this. And then of course prostadine and misoprostol, the prostaglandin derivatives are there. Now coming to carbetocin, which is a next generation drug for PPH management. So carbetocin was basically created by making several modifications to the oxytocin structure. And the changes that were made were that it prolongs the half-life of the carbetocin. See, the half-life of oxytocin is less, but the half-life of carbetocin is somewhere between, I think, 80 to 100 minutes. And the carbetocin has a reduced enzymatic degradation. So the action is quicker and it is retained for a prolonged time. Now with oxytocin, we had to give the patient maybe at times continuous oxytocin infusion to prevent the PPH. But carbetocin in such cases, a single dose can be very helpful in contracting the uterus and then maintaining that. So it is a synthetic long-acting analog of oxytocin, and the therapeutic indication is preventing PPH due to uterine atony. And one vial contains 100 microgram of carbetocin in 1 ml solution for injection. Now coming to the clinical evidences, efficacy and safety of carbetocin versus oxytocin. Now, WHO had undertaken a big trial which was known as the WHO Champion trial, and in this, carbetocin was proved to be non-inferior to oxytocin. Carbetocin decreases the need for utrotonic agent. Single dose carbetocin versus continuous infusion of oxytocin, as just recently I told you. And then comparison of carbetocin versus oxytocin with respect to the reduction in blood loss and the need of other intervention. And efficacy and safety of carbetocin versus symptometrin. And efficacy and safety of carbetocin versus misoprostol plus oxytocin, and we can also add this prostaglandin injection prostaglandin here, that is the carboprost. Now, a word about the WHO Champion trial. Champion trial is carbetocin hemorrhage prevention. This was the largest clinical trial in prevention of PPH. It was conducted by the WHO, and of course, India was one of the countries where from where the patients were enrolled. There were 30,000 women across 10 countries, including India. And the study design was non-inferiority double-blind randomized trial. Objective was to compare the effectiveness and safety of investigational heat-stable carbetocin to oxytocin in the prevention of PPH after vaginal birth. The primary outcomes were two: the proportion of women with blood loss of at least 500 ml or the use of additional utrotonic agents, and the proportion of women with blood loss more than 1 liter. So this table beautifully shows that carbetocin is non-inferior to oxytocin in the WHO Champion trial. So you can see that whether the blood loss was more than or equal to 500 ml or with the use of additional utrotonic, the efficacy in both is comparable. 14.5 in carbetocin versus 14.4 in oxytocin. Similarly, if we talk about the safety profile, if we talk about the adverse effect, they were comparable. So it was proved that carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional utrotonic agents. Now a word about the Cochrane review about carbetocin for preventing the PPH. In this Cochrane review data from 11 studies involving 2,635 women, the author concluded that for women who undergo C-section, carbetocin resulted in a statistically significant reduction in the need for therapeutic utrotonics compared to oxytocin. It is also associated with less blood loss compared to symptometrin in women who have vaginal deliveries, and is associated with significantly fewer adverse effects. So now coming to the guideline recommendations, you can see that this is recommended by the various bodies like WHO, who started recommending this from 2018. And other than oxytocin and the prostaglandins and the methylergometrin, carbetocin is one of the utrotonics in their guidelines. Of course, the Society of Obstetrician and Gynecologists of Canada, the New Zealand, then even FIGO, the German Society, the FCOG, France, they all have started recommending carbetocin. This, though, is not available in the US. So I think with that, Dr. Prashant, I finish my presentation, and then we can take up the discussion.
Madam, you can stop sharing this. I will share my slides and come to questions.
Okay.
Is it visible, madam?
Yeah, this is visible. Yes.
You said, madam, you have been using Carbetocin over past 2 years or so.
Yeah, since the
What is
time
your
of its
yes
launch.
launch around 2 3 years? What is your general experience, overall experience about Carbetocin in terms of efficacy and tolerability as well?
See, general experience with carbetocin is good, but at times we do experience little bit of side effects like maybe nausea, flushing,
Exactly.
headache, maybe little bit of hypotension, very transient hypotension.
Correct, correct.
These type of things are managed, and at times, we do have to use some other utrotonic other
Yes,
than
yes, yes, yes.
carbetocin also.
And PP is a condition where one will not wait. I mean, it's a condition with a potential very dangerous.
Yes,
Yes,
because
yes,
that is
correct.
one thing which has to be managed very
Absolutely
fast.
correct. Absolutely
Yes,
correct. And this is one place where you'll use all possible drugs, not one.
yes,
Correct.
yes,
Although we can expect PPH in any patient,
yes.
what are the specific patient profile where you can anticipate a PPH?
See, any patient, a multipara to begin with, and multipara, then patient with multiple pregnancies, then patients of PIH, patient with the hydramnios. All these patients, I think we can
Okay.
anticipate people. Then patient in labor who are in prolonged labor, or patients who have been handled by the dye in the periphery, and
Yeah,
many
yeah.
a times they are referred.
Correct.
So obstructed labor. So PPH is one thing which can be anticipated in most of these patients.
And I mean, any condition basically which can lead to uterine atony can produce PPH because this drug
Yes,
will be
yes,
effective
yes.
in uterine.
Yes. And at times, there is no precipitating cause. Like I gave you the example of
Yes,
my
yes,
third
yes.
patient. So we had, though the bleeding was not very much, but the uterus was atonic.
Atonic. And
And
you
we
have to
had to
use
use
almost all drug.
practically, yes, we had to
This is
use
another thing.
practically all the
Almost all drugs.
utrotonics.
Yes.
Yes,
It's very funny now because what appears to be simple is not necessarily simple.
yes.
When would you actually prefer carbetocin over oxytocin for prevention? I mean, in all the atonic labor, high risk patients, I understand. You have answered this, but
High risk patient,
specific,
and of
yes.
course nowadays in elective cesarean,
Okay.
that is one of the indication where carbetocin can be used, and normally it is given by the anesthetist who is on the head end of the patient.
Yes.
So normally in most of our elective caesars we are using carbetocin,
Correct.
and of course even in our vaginal deliveries we are using carbetocin. But we do use oxytocin also at times.
Of course, a textbook drug, madam.
Yeah.
In case of recent placenta, any experience that you had of using carbetocin in recent placenta?
Yeah, even we had experience of not maybe not more than one or two cases, but I was when I was preparing for this presentation today, I came across an article somewhere in, I think the area is somewhere Benha or somewhere like
Ah,
that, where they had a study on 90 patients with retained
yes,
placenta,
yes, yes, yes.
and carbetocin was given intra-umbilical
Correct,
in those
correct, correct, correct,
patients,
correct,
and a
correct.
comparative study was done versus carbetocin versus oxytocin.
Oxytocin.
So it was seen that in the patient where carbetocin was used for retained placenta, the separation of the placenta, the expulsion of the placenta was faster, and also the amount of blood loss was comparatively less
Less.
as compared to oxytocin.
Any individual experience you have, madam, on this retained
We
placenta?
had one or two patients in where that was, I think, second trimester, this thing
Oh,
abortion,
oh, oh.
and
Yeah,
then we had a retained placenta.
my
But
God.
yes, we did use carbetocin in that, and the placenta separated
Separate.
maybe
Right.
little bit. I mean manually I just
Yes,
found the
yes, of
cleavage
course.
and
Yes, yes,
separated
yes,
the
yes.
placenta, but then that came out beautifully, and there was hardly any PPH.
And would you use carbetocin in RH negative mothers?
Yes, we can, because there was a myth that utrotonic should not
Correct,
be
correct,
used
correct,
in
correct,
Rh
correct.
negative patient, but now most of the guidelines, even the FOGSI guideline, the RCOG guidelines, they do say that because we have to prevent PPH or we have to do the
Absolutely.
active management, and whatever feto-maternal hemorrhage we are expecting, that can be covered by the use of injection anti-D.
Correct. And if someone gets in the periphery of PPH with RH negative, getting blood is an impossibility.
Yes, yes.
Yes.
So we have to think about the RH immunization
Correct.
part,
Correct. Correct.
isoimmunization
Correct. Correct.
part at a later end, but
Right.
the primary aim should be to prevent
Stop them.
PPH.
Correct.
So we can use carbetocin, and then we can certainly give anti-D if required. and depending upon the feto-maternal hemorrhage that we have anticipated, if needed, there are tests available where we can give a little bit higher dose if the amount of feto-maternal hemorrhage is more.
Can a doctor use carbetocin for prevention of PPH if oxytocin has been used for labor induction?
Certainly, certainly.
There's
We
no
can.
question. In which cases you would prefer? I mean, you have been generally using IV, you said, with anesthetist help and
PVA,
cesarean
yes,
section.
because
But
we
is there
have
any,
our anesthetist here,
yes,
and
is there
we
any
have
place
even,
for iron?
yes, yes. So
Any
it can
place for
be,
iron? Yes,
since we are having a IV line, we have anesthetists, we
yes,
have the
yes,
whole
yes.
OT and the labor room
Correct,
staff.
correct, correct.
We are normally using it by
IV.
the IV route, but even IM route, whichever is convenient for the obstetrician, they can use it that way.
And madam, what is your take on a prefilled syringe for IV use?
But which cases would you
No,
prefer
no,
IV route?
no, I'm asking, what is your take on prefilled syringe?
Prefilled syringe of carbetocin.
Huh.
I think we are not having that prefilled syringe at present.
There are some available. Some brands are available as prefilled syringe. But
Okay.
would they be? I mean, I personally thought it would be a great advantage because you
It
save at
will
least.
be
Yes,
if the price difference is not
correct,
very high.
correct. Yeah,
Because as such, see, anesthetist is using that in
yeah.
our elective cases.
Uh,
So as such, many a times we do give it IV slowly. But in some of the patient, in the beginning, we started having that transient hypotension and
okay, okay.
tachycardia and flushing. So many a times what they are doing is that they are putting it in a 100
Drip.
ml normal saline and then infusing that.
If patient, in fact, you have a case, you have with patient not responding adequately with carbetocin, you have used almost all ultrasonics. That case
Yes.
we saw.
So normally actually
Very
we
interesting
keep
case,
the,
huh? Appearing very simple,
and practically there was no, risk factor for this patient.
Correct,
And
correct.
even we were very surprised and very, apprehensive also, because normally in these patients, normally one utrotonic is more than
Yeah,
sufficient.
yeah, yeah.
But then here I like to discuss one thing with you, Dr. Prashant, that
Yes, yes.
initially when carbetocin was launched, it was said that once you have used carbetocin, you cannot use oxytocin because
Because the
the
receptors are same.
receptors,
Yes, yes, yes.
receptor. But yes, very interesting. Interestingly, I like to tell you that in many of the patients
Huh,
where we did not get the desired result with carbetocin,
huh.
I did use 10 units of oxytocin or maybe at time 5 units of oxytocin IV slowly. And
Huh.
the result was really good.
Oh, that's wonderful.
So I
So,
think you people will be able
yes,
to
yes.
explain that in a better way.
It is a definitely a matter of, more detailed analysis, but really
Yeah.
interesting, really interesting.
We did use because
Yes,
initially that thing was there in our mind that no, we should not use. Then we said, why not?
correct.
Anesthetist says, okay, before giving prostaglandin or anything, let us
देख
try
के देखे ना,
oxytocin.
देख के, correct.
Yes, and the result was really good.
Very, very, very interesting. That's why they said, practical experience is something which is
This is
priceless.
practical,
Yes.
yes, because we all know that the receptors are full and the oxytocin
And
will
coming
not
from
be.
doctors who have used it and their own experience is wonderful. This is what we exactly want our doctors to
Yes,
know.
yes, yes. So 5 to 10 units of oxytocin we do use at time where we are not getting the desired
Correct,
uterine tone
correct,
with
correct,
carbetocin.
correct. What are the advantages of carbetocin over oxytocin? But here, particularly, I want to ask, have you seen that ADH-related side effects with oxytocin? Water retention, sodium, etc.
With oxytocin,
Huh,
very less.
very
I
less.
don't think so because see, we are using it in a very therapeutic way, I think.
And systematic
So,
way, yeah.
yes, yes. And monitoring of the patient, especially where a good number of units are used, we are
Correct.
keeping a very watchful, these patients are kept in the CCU and very watchful. So,
Correct.
practically, we have not seen much side effects with oxytocin.
Oxytocin. And misoprostol, carboprostol, methyl ergometrin.
Yes, carbopros that you have to be little
Asthmatics.
particular about in the patient in asthmatic patient,
Asthmatics.
and of course that nausea, vomiting, and
Diarrhea.
diarrhea
Yeah,
and
yeah.
abdominal cramps. These things can be there with both with the misoprostol and
The
carbopros.
prostaglandins ultimately.
Yeah, and at times that wherever we are using this misoprostol, that those chills and shivering are not have been seen in this type of patient. Methyl ergometrin, of course, we are using very very less because long back I have seen several patients going into ARDS using methergine.
Oh,
Simple patient, no
Achha.
PIH, nothing. In PIH, of course, we are not using methyl
Okay.
ergometrin,
The
but
blood
we
pressure
did
shoot up
see,
suddenly.
yes,
Yeah.
though by the grace of God, all those patients came out safe. But then, we have started using methyl ergometrin very, very less.
Okay.
Like if the BP is normal and the patient is having little atony with carbetocin, then maybe as second line we use 1 ampule of methyl ergometrin. Otherwise, in routine, we are not using this.
In my time, madam, I'm talking about the 70s. We had only two drugs, oxytocin and methyl ergometrin. But even then,
Yes.
the use of methyl ergometrin was less because there's a fear of blood pressure shoot up.
Yes, when we were doing our post graduation in 80s, I think
Yes.
87 to 90, we were using methyl ergometrin in every patient in the
Correct,
labor room
correct, correct.
because that was the only thing
Only
which
thing
could be
available.
used other
Yes.
than oxytocin. But then in 90s, maybe late 90s, there were several case reports also.
Prostaglandins, yes,
Yes.
yes.
So then I think use of methyl ergometrin that decreased, and that was the time as prostaglandin was introduced.
Should carbetocin be kept as a reserve drug? You already answered it using the first line.
Yeah, this is see, we are using as at a first line, but I think still oxytocin is the first line drug
Yes, yes.
because it is available more freely. The only
Correct.
thing is its
Cold
storage part.
chain, yeah, cold chain is an issue.
Yes. So in the remote areas where it is difficult to maintain the cold state or maybe cold store, or if it is difficult to keep it in the refrigerator,
Correct.
in those part, carbetocin should be the
The
first
first
line
line.
of management. Otherwise, it depends upon the obstetrician and the availability.
Correct. Although so many drugs have come, our amoxicillin still is the first line.
Yes.
Always. How will you compare carbetocin or oxytocin vis-a-vis adverse effect contraindication? Is there any difference, stark difference, or almost the same?
Almost the same, but
Almost the
yes,
same.
little bit I'll say as compared to oxytocin because we have been using it for pretty long time. Also using it as the active management of the third stage, maybe a little bit of nausea, headache, dizziness, transient hypotension is little bit more with carbetocin. But
Okay.
then if we infuse it IV very slowly, and I don't have much experience of giving carbetocin IM. So maybe
Yeah,
with IM, these side effects will
would be
be far
less.
less. Yes.
Yes. And last slide, your one liner on carbetocin.
Beautiful drug because one of the advantages with carbetocin, is that it sustains the uterine tone for a pretty long time because the half-life of carbetocin is more.
Correct, correct.
So when the half-life of this carbetocin is more, the need for continuous that oxytocin infusion, what we were doing previously, that thing is not there.
It's wonderful.
So I
Sharing.
think I don't know, we have, I think, skipped somehow the mechanism of action of carbetocin. I don't know why that slide has. So if you
Yes.
can,
Uh,
if you want, you can discuss that
This
because,
otherwise also. But
yeah,
a very interesting case we saw was, cases where carbetocin failed. In the sense, it did not give adequate contraction, and we had to use
yes.
other electronic. It was a very interesting case. And of all the things, oxytocin also worked, where carbetocin didn't work. Generally, there is an
After,
impression, yes, with
yes, so we
yes.
had to practically use all the four drugs.
Yeah. I'm sure our doctors who have participated will benefit out of your experience, madam. It was a wonderful session, I must say. I mean, an eye opener in some of the cases of oxytocin use. Thanks once again. Thank you very much for these insights.
Thank you, Dr.
Yes.
Prashad. If there are any questions from the audience, I think we can
There,
take those.
no, they will be joining on other link, and if there are, there will share it with you afterwards, maybe. Or if they
Okay.
have. Listen, thanks all the doctors who have participated, who taken time from their schedule and participated in this webinar. Thank you, marketing and sales team of Hitro for conceptualizing, coordinating, and implementing this. Last but not the least, thank you, IT team Hitro. There's one question, madam, just come. After delivery of shoulder, if we have to use 20 units of oxytocin and method, 1 minute. After delivery of shoulder, if we have to use 20 units of oxytocin and methergine, then can we use carbetocin further?
Yes, sure. Why not? See, I told you like when we are using oxytocin, whether to use carbetocin or not is a question mark.
Correct.
But practically, we have seen that we can Though in this type of patient, if there is atony,
Huh.
then maybe after delivery of the placenta, prostadine will be a better option if there are no contraindication to the use of prostadine.
Thank you
Because
very
since we have already given methergine, we have already used 20 units, then the next drug of choice will be prostadine, but after the delivery of the placenta.
Thanks once again, madam. Thank you so much. This query came at the right time, as we were about to close.
Yeah.
Thanks, Giridhar, for prompt forward of this query. Thanks all of you for attending. Once again, wish you a very good afternoon and good evening. Thanks, madam, once again, and wishing in advance a happy new year and a prosperous 2025. Thank you.
Thank you
And
so much,
signing
Dr.
off.
Prashant.
Thank you.
Thank you, Hetero, and thank you, Dr. Prashant.
Thank you. Thanks, madam. We can
Thanks.
sign off.
Yeah.
Thanks, Giridhar.
Thank
Thanks,
you,
Priyanka.
doctor.